Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. This week is the general practice issue of the MJA. One of the authors featured is Dr. Michael Wright, the president of the Royal Australian College of General Practitioners. He joins me now. So you're an author on the paper about voluntary patient enrolment, and does it lead to improvements in general practice care in Australia? And what motivated you to write about this?
Yeah, well, what we've been interested in is in Australia, we've seen the rollout of My Medicare, which is Australia's voluntary enrolment scheme. And up until 2023, when that system rolled out, Australia was one of the few OECD countries not to have a system of enrolment. And so what we wanted to do was to understand what's the international evidence about enrolment, and often what's the impact of introducing it into primary care. So particularly related to continuity of care and quality of care. I suppose as a starting point, don't we, like when we mean enrolment, the idea, like other people call it empanelment or registration, but it's basically the idea where a patient registers with a specific general practitioner or family physician, as they're known in some countries, or with a single practice. And so enrolment is seen as one component of high-performing primary care that, ideally benefits patients, GPs, practices, and the community by supporting greater continuity of care and coordination of care, and also leading to better health outcomes. So we really just wanted to know what's the evidence base to support that.
Okay, and so what did you find when you were looking into it?
Well, what we did is we did a scoping review. We had ended up including 24 papers from between 2014 and 2024, one international review, a rapid review, and then the others were evidence from 15 countries. Most of them were from Canada, a few from Australia, and then a smattering from all around the world. And so, as I said, what we wanted to know was what was the impact of enrolment. And I think one thing we found was that in all countries that introduced enrolment wasn't the only thing that happened at the same time. So often there were other structural changes, other funding reforms introduced. And that's what we were quite interested to see, that enrolment didn't happen in isolation. It was often related to other changes in service delivery. I think one thing we found is that people were more likely to enroll with a GP or a practice when they perceived that there were benefits to enrolling. So regardless of how the enrolment system was structured. And we also found that actually the people who were more likely to enroll were probably also the people who were already had a usual GP. So older people, people from high socioeconomic areas, people with multiple chronic health conditions, they were all more likely to enroll. And I suppose the reason to highlighting that is that when we looked at the evidence, did enrolment improve continuity of care? We actually found it didn't make much difference. And we looked through the results, and what we think is it's actually because we already had pre-existing high levels of people who were already, shall we say, informally registered, or in that they were already had a preferred GP who they were going to, and that when enrolment was introduced, it didn't make a great deal of change to the behaviour. So when we were looking at did it improve continuity of care, the answer was, well, we found little evidence that it did, but that's because there was already high levels of continuity of care. So we also found that the nature of enrolment, so how the system was set up, whether it was voluntary, whether it was mandatory, and also the associated reforms and rates of enrolment really varied. And they also varied according to the incentives that were introduced. We also found that where there were stronger incentives, I think both for providers to enrol people, but also for patients to enrol, that was associated with increased enrolment. And I suppose to explain a bit further, so if enrolment in some countries was associated with better access to services or some financial incentives, such as lower out-of-pocket costs, and in those schemes, rates of enrolment were higher, whereas they were lower for schemes that had weaker incentives. And one of the things we've found from this research is that potentially we do need to look at who are the people who are not enrolling. So in addition to monitoring the overall enrolment rates, perhaps we should be looking at who are the people who've got barriers to enrolment, who might include Aboriginal and Torres Strait Islander peoples or residents in people living in rural and remote Australia, older Australians or people living with mental health or disability. So I think that's what we've learned from this article. And to finish up, I think what we found is that patient enrolment often has this dual purpose of improving continuity of care and supporting primary care service delivery and reforms. And so we did find that there was some evidence of enrolment improving efficiency in primary care delivery, but we didn't find consistent evidence that it improved continuity, improved quality, or even that it improved equity. As I mentioned before, this might reflect the fact that many people already have preferred GPs, preferred practices, and therefore naturally select continuity of care, and that introducing the schemes without ideal incentives might create some concurrent but potentially unintended outcomes.
Do you normally submit papers to journals these days? Do you have the time to do that?
In addition to my work at the International Centre for Future Health Systems at University of New South Wales, where I'm an associate professor, I've recently become the president of the Royal Australian College of GPs. So the college work does take up a lot of my time, but I'm really pleased to see these research papers, which we've been looking at, try to understand how we inform health policy and design the health system that Australia needs, that these papers are still coming out. So it is great.
So on that note, now that you're the new president of the RACGP, there's also a new government. What kind of things would you like to see happen?
Yeah, but it's a great question. I mean, I think reflecting on the election that's just gone, we've seen general practice and general practice funding really being at the centre of the election. We've seen major commitments to increase the GP workforce and to reinvest in Medicare. And I think that's a great thing. Like all up, it looks like around $10 billion has been committed to increase funding to support general practice care, to support affordability and to support the future workforce. And so that's great to see. And I look forward to working with the future government to make sure that these additional funding announcements can support practices to provide the care that our patients need. I suppose if you're asking me what are the biggest challenges still, I think they are related around changing demographics and also our ongoing workforce needs. We do know that we have an aging population. More of us are living with chronic health conditions, and more than 60% of us. And a lot of us are living with multiple chronic health conditions, and dealing with that's more complex care. And that care should be provided in the community. And I think general practice can do it and does do it. But we just need to continue the journey of making sure that Medicare is fit for purpose. And then we also need to make sure that our workforce is fit for purpose, that we know we've got shortages of GPs, nurses, all other doctors and health professionals. And we really have to work together, collaborate more in multidisciplinary care teams in order to make the best use of all of our skills so that we can actually keep people well. So I think they're probably the two, the ongoing challenges that we have, but the demographic challenge and the workforce challenge, have been ones that we've had for decades. And so it's great to see some action being taken place to sort of improve and support the workforce.
How do you see the future of general practice in Australia?
Yeah, look, I think we've got over 40,000 GPs who are really trained in providing holistic care, trained in dealing with undifferentiated illness. And the more and more I see, I'm impressed by the skills and expertise and the capability of GPs have to keep people in our community well so that they don't need to use expensive hospitals. And I think that's great for productivity and that's great for our community. And I think that's where I see the future of general practice, in that trying to, as I said, maximize the productivity of ourselves, but also the productivity of the community, so that I think investment in general practice is the most cost-efficient part of the health system. It's also probably the greenest part of the health system, because investing in general practice is good for our health, good for our community, and good for the environment. Probably one other thing to add is, as GPs, we're a really diverse group, and I mean from backgrounds. The majority of Australia's GPs did their initial medical degree in another country. And that diversity is a really great strength, because it allows us to provide care to people all around Australia who live in diverse communities in every setting. So whether that's, rural settings or marginalised communities or culturally and linguistically diverse communities. And I think that's a really important skill that we have in general practice that we probably need to acknowledge and be proud of, and use those skills to a better degree.
One of the most enduring things about general practice is the relationship between a GP and their patient.
Yeah, look, I think you're fundamentally, totally right. Look, I can go back. My dad was a GP, and I actually grew up seeing this value of that doctor-patient interaction over time. And as you say, it's this relationship that develops. In this research that we've been doing, we talk about continuity of care. And so it is this benefit from seeing the same person over time. You learn more about each other, and even the interaction gets stronger. You're more likely to have shared decision-making. And the international evidence shows that having that continuity of care and that long-term relationship is better for your health outcomes. It's more cost-effective and more preferred by patients as well as by health providers. So that's why we thought it was important with this research to try and understand, does introduction of enrolment increase continuity of care?
Thank you to my special guest, Dr. Michael Wright. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.